before you institute any topical or conservative management for OSSN. There are various regimes which are available. Commonly used drugs are MMC, interferon, and 5-FU. MMC has a little bit of more side effects. That way, interferon is much more gentle. And 5-FU has now been found to be much equally effective as MMC with lesser side effects. So whatever protocol you choose, there are many protocols, but you have to ensure that these are non-invasive tumors and localized to the epithelium. For invasive tumors like this lady who has this massive OSSN, you have done an excision, but the sclera is involved, it is positive. So you can go for a plug brachytherapy for the residual disease and try to salvage the eye, like done for this patient. For other cancers which are already gone into the eye, like intraocular invasion where there is an uveal prolapse already, there is no other modality but to go for an extended enucleation. Moving on to retinal blastoma, intraarterial chemotherapy is now the talk of the town because it has shown very good results, especially in recalcitrant or recurrent tumors which are resistant to other modes of therapy. There are very specific indications of the eye which are suitable. Once you select the suitable eyes, at least in our study, we have found 55% eye salvage rates for tumor which are resistant to other modes of therapy. For the cost constraint, we are now restricting ourselves to only to secondary tumors which are failed other therapies, but it has also shown very good results in primary treatment for advanced intraocular retinal blastoma, group C and group D tumors. Intravitreal therapy is another modality now in an armamentarium, which is now been extensively used for management of vitreous seeds and has given very good results in salvaging those eyes which otherwise would have undergone enucleation. Earlier, melphalan used to be the drug. Now with topotecan, these are much more safer, especially in Indian eyes where melphalan causes a lot of toxicity because of the pigmentation of the PE. You can also go for an intracameral chemotherapy for anterior segment seeding. These are the tumors which earlier used to be again enucleated, but a selected group of this tumor where there are just isolated seeds without any invasion of the iris or the ciliary body, you can go for intracameral chemotherapy along with other modalities like ISC or IVC or a plug brachytherapy. Plaque is another modality which is very useful if you have it, especially for tumors which are resistant after chemo reduction, where you have done the chemo, but the tumor has localized but not responding further, especially the well-differentiated tumor. They respond very well to plaque. This child had a residual tumor in one of the quadrants. This was post about 8 cycles of chemo reduction, and we just did a plaque to the residual tumor and it responded very well. And it's almost a flat scar at about 6 or I think 7 months of follow-up. Just last bit, important thing to know for retinal blastoma is the genetics, because this is an important aspect now in the management. If you see this child and 2-month-old child presented with a group E unilateral retinal blastoma, and we know that group E unilateral retinal blastoma is a 2-month-old child is not normal. Normally unilateral tumor happens in older children which are the sporadic. This is very likely to be germline, but the other eye is fine. So unless and until we know the germline status of the child, we cannot follow up this child. This child has to undergo maybe unnecessary UA if it is not germline. So we got a genetic testing done. We found a mutation. The child was germline. We followed up the child. 3 months down the line, there was another small tumor which came up in the other eye. We could immediately catch it at a very small state and treat it before it has gone to extensive site. I think I'll skip this bit. Liquid biopsy, another thing which is coming up in a big way, at least for the management of retinal blastoma, where you can detect circulating DNA and get the same information which we get from the tumor DNA without doing enucleation of the eye. So this is a lot of potential for prognostication as well as for developing newer targeted treatment therapy. And I'm sure in the next couple of years, we are going to hear more of it with time. So this is what I had to say. This is my whole team. I acknowledge the whole team who contribute every day in treatment of the ocular tumors that we see. Thank you so much.
So questions will take now.
That's a nice presentation, Dr. Seema. I think because of lack of time, I think you have to skip so many slides, and also we would be run through the slides. That's one of the wonderful presentation. In fact, your videos are really fantastic. Thank you. I'll call Dr. Pratibha to present her presentation. During the presentation is ready, I just want to ask you one question. Do you have any now how about the mitomycin C? Is it being used or is it been totally obsolete now?
It's not that we don't use it, but we don't use it as a first-line treatment now, because the toxicity safety profile is definitely there. So we tend to start with either interferon or 5-FU, and if there is not good response to those, then we shift the patient to mitomycin C. Yeah.
Over to Dr. Pratima. Ready?
Yes. I have it in front of me. Good afternoon.
And the intra-orbital injections of the melphalan, do you get a guidance from the radiologist team? Yeah, definitely. Yeah.
Intraarterial chemo is done in a neurointerventional lab. So we can't do it in an ophthalmic setup. We need to have a neurointerventional or a cath lab, and they do the catheterization through the femoral artery. The catheter goes into the ophthalmic artery, and the drug doses and all we decide based on the kind of group of the tumor and how much is the extent of the disease and the age of the child.
It's like age dependent, or it can be given for even metastatic disease.
Yeah, it is. Yeah, any age group. So generally, we are not doing in patients who are less than 6 months old now, because the femoral artery catheterization, the technique is different. It's not that you can't do it, but it's technically a little difficult. So I think the youngest we have done is about 9-month-old child. Beyond that, we haven't done it.
That's nice. Yes, over to you, madam.
Yes, sir. Very good afternoon to one and all. And I'm Dr. Pratibha Devi Nivyan, and I'm here to present a few challenging cases in ocular tumors which I had faced in my practice, and I'll give few pearls which we should follow it in our regular practice. So this is a 55-year-old male who came to us with gradual progressive proptosis in his left eye over the duration of 5 years. He had a history of RTA 6 years back, and he lost his vision in his right eye. Since he was one-eyed, he was neglecting treatment, and when he started developing a defective vision in his left eye, he wanted to have a treatment. So he had a no perception of light in the right eye, and he had a vision of 6/18 in the left eye with an eccentric proptosis and lag ophthalmos with exposure keratopathy and a disc edema in the left eye. The apparently good eye had no vision. This was his imaging picture. So the scans shows gross proptosis with mass lesion involving almost the entire left orbit, encasing and molding the globe without causing any indentation of the globe. So this is very pathognomonic. The molding of the globe and no indentation is very pathognomonic of lymphoma. So in any case, we have to do get the diagnosis by doing a biopsy and then doing a histopathology and immunohistochemistry. But doing a biopsy in a patient like this is a little tricky because the patient already had a very tense globe, and a biopsy could cause bleeding inside and intra-op or post-op, causing no perception of light in his seeing eye as well. And on careful examination and as a blessing in disguise, this man in his right eye had a similar conjunctival lesion in his lower subconjunctival space, the typical salmon fish appearance or the fish flesh appearance suggestive of lymphoma. So we took a biopsy from the right eye, and immunohistochemistry and histopathology was confirmed, and the management was done, and this is the patient after radiation. Similarly, this is another gentleman who came to us with complaints of left lower eyelid swelling with a mild proptosis in left eye. So this patient, the CT and MRI scans were suggestive of lymphoma. The typical mass lesion caused molding the globe without any indentation. So we did an incision biopsy. We sent for histopathology, immunohistochemistry, confirmed it to be lymphoma, and we gave radiation, and the patient was like this post-op. In 2023, he again came to us with a right eye lower lid swelling. So I reviewed back the scans which we did earlier, and I noticed that there was a subtle small lesion in the right eye even during that period. Probably that was missed, or the lesion was so insignificant we could not have picked it up. So this made me think that so we should understand that in any orbital case we should also look into the other eye. There might be a lesion similar or might be subtle compared to the other eye. And the reason in lymphoma for the bilaterality is the MALT associated lymphomas are said to have bilateral lesion because of the homing effect. The cells adhere to the epithelial surfaces. So the bilaterality is more common in MALT-associated lymphoma. This gentleman came with a swelling in the right eye upper lid. So as a general ophthalmologist, one should carefully look at the swelling. When to decide when to do an incision biopsy or when to do an excision biopsy with a margin clearance. So loss of lashes and lid margin architecture alteration are the two main things which we should look for deciding on the treatment. And since there were loss of lashes and lid margin was altered, I planned to do a excision biopsy with margin clearance, and the patient came again for a review in 2021. I found that there was a small nodule seen again in the upper lid. So again I had advised him an excision biopsy with margin clearance. I did an excision biopsy. I do not have a frozen section, but the COVID lockdown came and the patient was lost to follow up. Again he came back sometime later with a keratinized lid with conjunctival congestion and pain. So we planned again to do a lid margin excision with margin clearance, and the patient was like this. The patient is due for a lid reconstruction. So the pearl here is, these cases are not a single line of management. That doesn't stop with a single treatment. The patient has to be explained about the nature of the disease, chance of recurrence, and lifelong follow-up is needed. This is yet another case where there was a left diffuse thickening of the left eye upper lid. There were loss of lashes. The lid margin architecture was completely altered. Clinically, this patient is definitely suspected to have a malignancy. Yes, the histopathology confirmed it to be a squamous cell carcinoma. So this patient underwent an excision biopsy with 5 mm margin clearance, and then I did a lid reconstruction with the buccal mucosal graft and a forehead flap, and the patient was like this. But unfortunately, the patient came back again last year with a recurrent, very aggressive swelling like this. So the pearl here from this case is, always involve colleagues in management of such cases, because there can be medico-legal issues as well. And this patient actually finally ended up with exentration. So have a tumor board meeting for decision making. I do a freelancing of oculoplasty surgery. So one fine morning when I went to do a surgery in another hospital, there was a case of a 35-year-old female who had painful blind eye, and she wanted cosmetic correction. So I said, it's just a normal case. Let's go ahead with an evisceration and ball implant. So on table, this was a surprise. There was a firm mass kind of lesion in the while scooping out the uveal tissue. So we did a histopathology. Luckily, that was not a malignant lesion, and oncologist's opinion was also obtained, and we are following up the patient. But the pearl here is, never take up an evisceration before doing a B scan. Might it be a own practice or might it be a freelancing practice? In suspicious cases, we should not hesitate to do even an MRI scan. This is another child who had an eccentric proptosis, who gave prominence of eye on and off, aggravated with respiratory infection, and this child had acute decrease in vision, came with an acute decrease in vision. So her vision was hand movements, and there was an RAPD with a hyperemic disc. So her scans, this was her scans, and there was cystic lesion occupying the entire orbit, sandwiching the optic nerve, causing the compression of optic nerve and hyperemic disc. So this child had a with the history and the findings, this child was said to have lymphangioma with bleed and optic nerve compromise. So we did, and we gave IV steroids, and then we took her up for ultrasound guided aspiration of cystic fluid and gave bleomycin to collapse the cyst. So the pearl here is, always follow less invasive techniques over complicated or in more invasive techniques. This is my last case, and this is a young girl who came with just a small lesion, with just I did an excision biopsy, and it came out as xanthogranuloma. And since it was a very rare presentation, we published it in 2017, and unfortunately in 2022 she came back with multiple swellings like this. And not all xanthogranulomas present like this, so we might get swellings like that as well. So all yellow lesions are not xanthelasma, and HPE is definitely mandatory, and chances of recurrence has to be explained to patients, and in recurrence we can give steroids in those cases. So to conclude, orbit and oculoplasty is a Pandora's box. Every day is a learning. We learn from patients, but we should keep the basics in mind. Thank you, AIOS, for the opportunity.
Thank you so much, ma'am. That was wonderful collection of cases. So we can move on to the next speaker. Sir, you want to take
one simple question that what after the excision you follow which technique, for Cutler bird or Tenzel flap for reconstruction?
For which case, sir?
For reconstruction of your tumor.
Which case?
For the lid tumor with present as something like
based on the size, sir.
Okay.
So if it is just a small defect, we will first try for a direct apposition.
Okay.
And in older people, we get a lot of lax skin, so direct apposition will help. If it is in younger patients, we might not have lax skin, so we have to do a canthotomy, cantholysis, or do a tensils to get some skin for us to do a direct reconstruction.
Okay.
If the defect is large, then we prefer
No, in your case, which technique you follow?
I put a graft for that man with sebaceous with squamous cell carcinoma. I put a graft for posterior lamella. I took the forehead flap for the anterior lamella.
Okay, but because I'd like to know that suppose you get an recurrence very frequently, will you suggest any radiotherapy for such type of patients? Radiations?
Radiation, yes, for lymphoma I had suggested. For sebaceous gland lymphoma, I discussed with the oncologist and then we take up.
If there is any skip lesions and all, we can advise them to go for radiation.
Sir, as a neoadjuvant chemotherapy I had tried, sir, as a primary treatment, but not radiation as a primary treatment. I don't know. You can give your inputs on that as well.
Right, good. Thank you, madam. And moreover, that xanthelasma, as you told, no. Now the presentation of xanthelasma is not simple as xanthelasma. It's presented in various forms. Like as you told us, something like a granuloma formations. So it's very difficult to treat such type of patients also. Right. Thank you, ma'am. Thank you for the presentation. Next speaker, I call Harminder. Please.
Dr. Hardeep.
Hardeep, sorry. Actually, I saw Hardeep almost 10 years back. He was a little small. I can tell us something like a kid. Now he's become like a big old man. Yeah, I think around 2012, I was amazed to get the talk. I listened to a talk by this one. So he was talking about the DCR, steps and steps of DCR. Still, I could remember. Yeah, in Kanpur, I think you are giving the talk. So one of the wonderful presentation. Over to you, sir, please.
I have two talks, so I will continue. I have two talks. I will present any talk first. Thank you, sir. Good afternoon, everybody. So I will be talking on the surgeries on the lateral cancer. As we all know, the main culprit at the lateral cancer is the lid laxity is there, and there are different procedures and procedures are available. So I will be elaborating the minimal invasive surgery at the lateral cancers. As we all know, the anatomy of lateral cancers, that the it is a fibrous structure that arises from the upper and the lower pre-tarsal oculi, and it inserts on the lateral orbital margin, slightly anterior and posterior to the lateral orbital margin, which is lateral orbital tubercle, if you see the diagram on the right side. So mainly the thing is, the problem is the horizontal laxity, dehiscence or disinsertion of the retractor, which leads to malposition of the lid margin. So how to evaluate? So you can do 3 tests, like distraction of test. You move laterally to see the punctal position in relation to limbus, or snapback test. You take away the lid inferiorly and see how quickly, how fast it comes and opposed to the globe or not, whether punctum is visible or punctum is not visible. In this way, the different classifications are there. The third is the pinch test. You pinch then see the laxity, whether you are able to pinch the lid of tarsus or not. So this is the basically grading for assessment of lid laxity given in the books. I'm not going into the detail. So as we all know, that the aging is a progressive. So no surgery is designed to correct aging changes that can be completely corrected. So I am showing 3 procedures: lateral tarsal strip, then suture technique, and ligament plication, which is canthopexy also. You do a lateral canthotomy incision, it was not recorded by chance, and do the undermining and separate the orbicularis skin complex from the tarsal plate. Do the cantholysis, to free the lid margin. I'm tackling the only lower lid right now. So retract the lid, see the how much, estimate the how much amount of lid has to be excised. RF cautery is the best tool for this with cutting and coagulation. Cut away and separate the skin complex and make the cut the tarsus in the shape of tongue. And you have to pass the suture in such a way from the slightly interior from the lateral tubercle from the lateral margin, and double arm suture is passed. Even you can pass double knot at the margin, but there is a good tissue is available, and take a very good bite so that it should not retract, it should not cut through, and tight the suture in such a way that there should not be over tightening and there should not be laxity also remaining. So the suture is tight, and extra part of the lid, this lateral canthal tendon is closed. And the next step is very important, that you have to form the lateral canthus. So 6-0 Weichel suture is used, and 6-0 Prolene suture is used for fixation of the LTS. Now lid margin is created, and a very sharp lateral canthus is formed, and you have to close this incision into 2 layers. First orbicularis complex, and then skin. It's a very simple procedure, but the only thing is that good hemostasis and selection of the case is very important. Now, these are few examples with the spastic entropion lid laxity. So the LTS was done. This is a grade 1 where the only punctum was there, but lid laxity was quite lid laxity. So these are few cases of post. But if you see this case, there is a lot of laxity, and there is shelving of the grade 4 ectropion is there. So in such cases, you may have to combine 2 procedures like LTS and Kunz-Zimnowski, which you have to remove the pentagon of the skin of the lower lid. Now this is the minimally invasive suture technique. Only canthotomy is done. Very small skin incision is basically given. Not canthotomy is done, because we are not touching the canthus. Canthus as it is. This is now a very good bite from the periosteum is taken, so that it should not cut through, and assessment already been done preoperatively. How much laxity is there, how much we have to tight the skin. So this is a 6-0 Prolene suture is passed in such a way that it comes through away from this area, and good bite again is taken from the periosteum, and it is tightened. The only thing is slight bunching. You can say it appears temporarily on the table, but it disappears later on, and you close the skin and orbicularis complex. So this is a very quick 5 minutes procedure. So this is done. This is a patient of operated mandibular carcinoma, and patient developed facial nerve palsy, and the patient was bedridden and was not able to come. So I have gone to his house and done on bedside. So this suture technique is very excellent, very dramatic results it gives. Now this is the patient with canthal laxity, and plication of canthopexy was done, given skin incision, and double arm vertical mattress was done and fixed on the lateral canthus. I don't have the movie for it. Now there are different conditions also, like they may mimic like ectropion or entropion, but they have different remedies available, like allergic and dermatitis. They cause ectropion, or so basically we have to require to treat the underlying pathology. Don't rush or don't confuse with for beginners. So in conclusion, canthal tightening technique is very effective and minimally invasive procedure. Proper examination and evaluation is very important to implement a correct procedure. Rule out any other inciting factor like allergic dermatitis. And the last and the most important, the clinical photograph is very important, pre and post operative. Make a practice to take all clinical photographs so that you can ensure the patient that what are the results post operatively. Thank you very much.
Thank you so much, sir. Sir, can you please throw some light on how will you go for lateral canthal tendon repair in case of dystopia? Sir, like in cases if there is any trauma and if there is lateral wall fracture, sometimes people end up with lateral canthal dystopia. So, sir, how do you manage those cases?
You see, in most of the cases, you can identify the lateral canthal tendon unless until the tissue loss is there. If the tissue loss is not there, then it is a very easy procedure, same as I have shown already. You just examine properly, reoppose all layers before going any suturing, and just see whether is there any tissue loss is there, do retraction, do oppose, see the anatomy. In case you think that there is a skin loss is there or some lid loss is there, then different procedures are available. If less than 1/3 is there, you can then it can be opposed directly for few days, depending on the age of the patient. Young, it will take some more time. For laxity, like old age people, middle age, it take less time. For aperture problems or disfiguring little bit for some time. Otherwise, we have to take graft from the ear tragus. You can take if there are a lot of things loss is there. Use the upper lid conjunctiva and free graft. All these procedures can be done depending upon how much lid loss is there. Like more than 50% loss is there, then we have to composite graft we have to use different layers because we have to replace all layers. And God has made this eyelids are so important, and every time whenever you talk to any person, you look at the eye. So disfiguring is never tolerated by anybody.
Thank you so much, sir.
Actually, you told it the canthopexy, you make it at exactly at the lateral margin.
Lateral margin slightly below. There is a little tubercle. You can say 1 to 2 millimeter below. You put the needle in such a way that it goes down.
Okay.
The needle erupts from the orbital margin, but it first passes from the tubercle.
Okay. Okay.
Yeah.
Right. Good. Thank
you. Just a minute.
Lateral tarsus procedure is one of the very good technique, normally being employed for even for ectropion and entropion also, unless and until when you have an vertical lid laxity is not there. If you have only the horizontal lid laxity, the choice is definitely in lateral tarsus procedure. Suppose in addition to it, if you have vertical lid laxity, you can just put a simple everting suture in case of entropion.
Yes.
Yes. Thank you.
My next talk is how to perform a successful DCR. Anyway, the DCR in the beginner days, even I love to do DCR. Many people don't. Out of 10 people, 1 people, I am the first person who love to do DCR, and people come to see my DCRs. I am never fed up with the DCR. So everybody knows as that there is a lacrimal duct obstruction is there. There is a triad of 3 complaints. Like watering is there. You always, when only watering is there, then you have to do syringing. You have to see the punctum. When swelling is there, discharge is there, and rhoplas is positive, then it is 100% sure that NLD block is there. Then you don't have to do any other investigation. Now, how to proceed in DCR cases? So rhoplas is very important. Once you just put a finger over the medial canthal ligament, you will see the discharge is there. That means patency is there. NLD is blocked, but the all canalicular apparatus is patent. So don't do unnecessarily syringing, because iatrogenically you are damaging the punctum, your canaliculi and other things. You are correcting the things, but still patient is having watering in most of the cases, because in when we were junior resident, they are just breaking the needle and doing them, because they all crenated margins. They cause erosion, abrasion in the canalicular area, and they further cause stricture. So syringing should be done only for academic interest, for beginners, to just 3/4 syringing just to know how it is done. Otherwise, it should not be done routinely. So as you know, all this pre-cycle and post-cycle, just to show that after syringing a probe is passed and whether it is a canalicular block or common canalicular block. And the other assessment is very important. Hematological examination is very important, because DCR is a surgery in which there is a lot of bleeding. Normally bleeding is not there if you are in proper space and you proper evaluation and good instruments and good visualization is there. Bleeding is never a problem. But in case their oozing is there are a lot of medicine are there. You can give 10 extra medicines are given 2 tablets just before 1 hour before to the patient. Bleeding is lessens. Use adrenaline, or when there is a contraindication to adrenaline, then it is a problem in some cases where we have to otherwise use GA cases or patients where are very very. So BT, CT, PT and all these investigations are very important. History of the patient taking care of trauma. Trauma causes surgical landmarks more difficult to operate, and results are the success rate decreases. So all these things you have to pre-operatory you have to do the assessment. Now nasal examination is very important. Anterior nasal cavity we can see, but if there is a DNS or some growth is there, I have got a problem in one patient because I am also freelancer. I gone to Patna, they didn't examine and nasally. So I was in problem. First time in my 30-year practice, I basically aborted that case and sent immediately to the ENT surgeon, and he said there is a very big polyp is there. And the moment I opened the lamina papyracea, suddenly bleeding stopped. And I had done all efforts. Bleeding was not at all stopping. So I packed it very immediately and sent immediately within minutes to the ENT surgeon. So ENT don't think that you are sending your patient to somebody else. If you are in doubt, always do endonasal examination and give pre-operative nasal decongestion at least 1 week, so that good sac flaps are made. Because a lot of people are having this URI problem, NLD block, and many things. So this mucosa is not healthy in most of the cases. So decongested is very important. So the local anesthesia is given along with adrenaline. And the main problem why DCR fails, because the site of ostium is very important. When there is a abnormal position, inadequate size, or abnormal direction is there, then we are lost somewhere. Sometimes you go more superiorly, sometimes you enter the maxillary sinus. So these are problems happens with the beginners, junior residents. So a senior person has to be there to dictate basically where the position is there. So now I will show the small DCR clip. So I normally press the anterior lacrimal crest with the spatula to mark the incision site, and exactly over this medial canthal ligament you dissect undermine the orbicularis, go directly to the lacrimal bone, and take care of the periosteum. Don't cut the periosteum. The things are retracted laterally along with the sac. Now I am retracting the periosteum. Now this is the area where lamina papyracea is there. You just break and don't go inside. Go inside and lift it laterally, so that you should not injure the nasal mucosa. Start with a small punch, then shift to longer punch. You remove the whole lacrimal crest, one punch, and then see approximately your little finger should be able to insert into the this cavity, this ostium. Now retract the periosteum, because in case where there is no the sac flaps or the periosteum can be used, but also it also bleeds if you cut the periosteum along with other structures. Don't forget to inspect the area where there is a small bony fragment, so that you remove everything. Now here you see the tenting is exactly in the center of the ostium. That means your cutting is absolutely in the center. You don't have to further cut the bones. In case you think the tenting is not in the center, then you again remove this probe and cut again the remaining bone which is required. Now I normally remove the posterior flap. Anterior flap is fashioned very nicely, and you see reinforcement of the nasal packing is done just to blanch the nasal mucosa, so bleeding is less, and a good U-shaped flap is made. And the posterior flaps are given relaxing incision. They should fall down, or you can suture in case you are doing double flap. Now suturing is done very meticulously, taking care not to take that nasal pack into the suture. Otherwise next day when you remove, you will break the sutures. So 2 to 3 sutures are enough depending on the size of the flap. I normally put 2 sutures, but sometimes we may need 3 sutures, one in the center. When apposition is accurate, there is a good tenting, then there is no need to put this orbicularis suture and taking into this bite from the flap. But in case you think some doubt is there, you can take that bite and always close the skin in 2 layers. Otherwise it will give the depressed scar. So postoperatively it is same, but the syringing is very important next day, just to wash away all clots or fragments and if anything, and reassure the patient that we have done a good job. As my time is up, I will just highlight one case of this mucocele. Now mucocele is have a different strategy to operate. Give very superficial incision, take care of the mucocele, dissect from all sides, and expose the mucocele. Then idea is you can't proceed with this mucocele. You have to deflate. Then give a proper incision, do a good suction, and make a good flaps, horizontal flaps of the mucocele. The only problem in this case challenging is it is long-standing mucocele. They are a very thin mucosa is there, so very difficult to suture. Sometimes cut through happens, and don't be cut short the flaps. So in case it is required, you can do double breasting, or you can exercise. If the good healthy flap is there, you can do exercise and then do the suturing, or you can double breast the both flaps. So this is the trick in mucocele. So main complication is hemorrhage, which can be managed. I've already told. So what is the conclusion? A good block, either in sedation or GA, good nasal examination, blood evaluation, complete history, good hemostasis. Instruments are very important. Your punch should be very good, cut in one shot. Otherwise, it will, if you twist like this, you will break, or you will go somewhere else. A large ostium should be made, and it creates a mucosa line drainage with primary intention closure with careful suturing of the flap. If sutures are not sutured properly, then you are in problem. And when you are passing the probe and it's not going properly, your probe is like this, and some bone fragment is there, and you saying your probe is not exactly in the center of the ostium, then you remove that bone also. Otherwise, first day only you will see that it is a failed DCR. So skin scar is not a problem. External DCR gives, I would say, it gives 99% in primary intention DCRs, and pre and post-operative decongestant are very important. Thank you, sir, for giving me time.
Thank you, Hardeep. I think that was a very good presentation on the external DCR. I think
my minimum time for DCR was 13 minutes with Dr. Maipal.
That's correct. The point I observed in his video is the denting. The denting of a lacrimal sac is very important. That he keeps as a guide. I know. I think some point he has mentioned maybe long back. He make a nick on the sac and hit on the bone, and that he keeps as center and make an opening. Maybe that's our point he was telling about 10 years back. Maybe that you are
normally
not.
Don't do this MPL cutting, not required.
Yes, that's correct. That's one of the very good procedures as demonstrated, and moreover that in fact the thing is that you have to always get an opinion from the ENT. Now the trend is totally changing, because the ENT opinions are very fond of doing endonasal DCR, and even now even oculoplastic, even I also started doing small little amount of endonasal DCR rather than going for external DCR, because we have some good colleagues of ENT people also. Right. But you should think in mind that always get an opinion from the ENT colleague, because in order to roll out your ENT causes for your NLD abstraction. Thank you, sir. I think I was just 2 speakers are left over now. I want to Sir. Sir, please.
At our institute, they do a lot of endoscopic DCR. Just I wanted to get some information from other ophthalmologists. How much adrenaline you inject when you are doing endoscopy?
He'll be right person. Is how much adrenaline you want to give?
It is already prepared.
Lignocaine with adrenaline.
That is enough. But sometime I do unofficially. I put 0.2, 0.3 ml into the vial. Yes. If the patient is not having any hypertension, CAD or something, so that gives very good hemostasis. The main trick is to give the anesthesia, then go for washing. Wait for at least 15-20 minutes to have the hemostasis good. Then when you cut, there is not even a single drop of blood.
Because they add in our institute, they add 3 ampoules of adrenaline or 2 ampoules of adrenaline and inject. So when they add 3 ampoules of adrenaline, we see a lot of arrhythmias. We are worried.
ENT people use very liberally.
That's what they say. When we ask them, they say, ENT people.
The only thing is that we can dilute it off. So how many vial you use, you just put more dilutions. I think because that can counter the effect of adrenaline, suppose. And
it is very dangerous.
Yes.
I used to do this much of adrenaline.
Okay.
Because, quite long back, I was operating a phaco. A patient was not dilating.
Okay.
I was doing freelancing right from the first day. Still I am doing.
Okay.
I go to many places. People call me and then I go.
Okay.
I used adrenaline epitrate.
Okay.
0.1
Okay.
It was AC.
Intracamerally.
Patient at the end of the surgery was not waking up. So he developed stroke.
Okay.
Because of that adrenaline.
Okay, that's what I was just in my morning session I was discussing with this sir. Like we had a doubt of use of the intracameral adrenaline and the effect of intracameral adrenaline on the post-operative outcome of the immediate post-operative outcome. But as said, we had a discussion, we came to the conclusion that the using of intracameral adrenaline doesn't have any effect as such, but this is like you told about one of the very rare events that has happened. So very unlucky. And I think I call upon 2 speakers if available. What the doctor? I think Dr. Shubhra Goyal is not there. I think one more speaker and another doctor. Another doctor? Dr. Shalil Bhargava. Dr. Shalil Bhargava. Yeah, please. Sorry, we left out. Just Shalil Bhargava will be talking on orbital imaging. Yeah, it's one of the interesting topic and also more difficult to understand. And because like based upon the advancement of the imaging techniques, and I'll ask Dr. Shalil to speak on orbital imaging. Thank you.
Is Dr. Binjia present here? Dr. Binjia?
I think the orbital imaging is one of the important tools as far as an orbital oculoplastic surgeon is concerned. Because whatever we see, if it is a chalazion also, once we operate on chalazion, we do INC, and if the patient comes with again in chalazion the same position, definitely orbital imaging has got some role. Because as Dr. Pradeep has clearly pointed out, when you suspect a case of lid tumors, is there when there is a loss of eyelashes and you don't see the contour or the anatomy of the lid is lost. These are a very important few factors, and there is an telangiectasia of vessels. These are very additional factors where you want to take into consideration where this lid, such a small lid swelling, can you think of something called as lid tumors. Okay, is it sites already, sir? Okay. We are running short of the time. I just yes, thank you, sir. Please, over to you.
We're going to start with the morphology of one lesion, which is an infantile hemangioma, and I will show variations of those images and how it changes the radiological diagnosis, right? So grossly, we'll just divide them into T2 bright and T2 hypointense lesions, and we'll move from there. Okay, so I'll just, okay, so now is my pointer visible? Yeah. Okay, so this is a 4-week-old child with a right orbital swelling. We can see here these are T2 weighted images because the fluid is bright, and you have a lesion here in the extracorneal space which is really bright on T2. It's got homogeneous enhancement on the post-contrast study. Now the 2 images which are there below are really pixelated. So I want you to familiarize yourself with saying diffusion weighted imaging. So this is a diffusion weighted image where it is slightly bright and slightly dark on the ADC map. ADC map is something that comes along with the diffusion weighted image, and you can put a little region of interest on the lesion and will give you a value. So this one was like 1.4 into 10 power minus 3. You don't have to care about the units. So these are findings which are very typical of an hemangioma. Some people call it an infantile hemangioma, some people call it a capillary hemangioma, but it is essentially a hemangioma vascular tumor. So ADVC values in hemangiomas are slightly higher. So things generally that are above 1 are more towards the benign side. 1.4 is a very good benign value. Things that go below 1 start moving towards malignant. Things that are 0.6, 0.7 are almost always malignant. This is a 38-year-old lady with an intracorneal lesion. Again, a T2 bright lesion. They're fine, I'm not sure if you can appreciate it, but fine septations inside it, which kind of resemble the pathology specimen. This lesion has good margins. Now, when we see a lesion like this, we do a dynamic contrast enhancement. Why do we do that? Because we want to see this finding of a focus of enhancement in the starting phase, which fills the whole tumor by the time you finish imaging it. And this is pathognomonic of a cavernous hemangioma, which according to the current ISWA classification is a venous malformation. So these are cavernous hemangiomas. The previous one was just a hemangioma. This finding of a point enhancement extending to the whole lesion is what we are looking for. So this is your radiologist, or you should advise your radiologist if you have a clinical suspicion of a cavernous hemangioma to do a dynamic contrast. This is another lesion which looks similar, but look at the enhancement pattern. In the early phase, it had a broad area of enhancement, very unlike a hemangioma, and this was a schwannoma. So dynamic contrast enhancement, very important for cavernous hemangiomas. Now, this is a 14-year-old child with another intracorneal lesion, looks again very similar. But what is different here is that although they are little septation-like areas, some vascularity within the lesion, the dynamic contrast looks like this. There is no nodule of enhancement, no spread. It's just a peripheral enhancement and central enhancement with little non-enhancing areas. So it's not really changed, it's not really filled in. And this lesion was also showing some restriction on diffusion. The ADC value here was less than 1, it was 0.9, and this is a embryonal rhabdomyosarcoma. Very commonly misreported by radiologists only as hemangioma and SEND, because we are not specifically, we don't have that knowledge that this embryonal rhabdomyosarcoma is common in children. And if our ophthalmologist will tell us, then we'll be like, yeah, we know what to do and how to figure that out. So here you need a dynamic contrast and you need a diffusion. Sometimes all the clues will point towards a rhabdomyosarcoma. Like this child had an enlarging lesion for 4 weeks, very bright on T2, deforming the globe, even causing stretch injury of the optic nerve, which is showing diffusion restriction. But the lesion itself is not that dark, and here the ADC value was high. So everything was pointing to a rhabdomyosarcoma except for the value. So in these cases, we forget the value. So don't let one finding change your entire diagnosis. So here it is supportive, not absolute. This is an adult extracorneal mass, very homogeneously enhancing. Now these are T2 slightly low. We've gone from T2 bright to T2 slightly low. Like ma'am had very nicely shown some lymphoma cases. This is also restricting on diffusion. It is sort of encasing the globe, and this is in the extracorneal space, and it is very characteristic of a lymphoma. So this, for us, we call this a dirty gray. Like you have a salmon flesh, we call this dirty gray. When we start seeing this signal intensity, where it's starting to become low, we really think of lymphomas. They can happen intracorneal, extracorneal. This is again a case where you can see the intense diffusion restriction. It's turning dark on the ADC map. Here the ADC value will be close to 0.7. Here you can have another one, extracorneal, going even into the pterygomaxillary fissure and the pterygopalatine fossa, almost like fungus do, but this is showing homogeneous enhancement and restriction. So this is also a lymphoma. Now T2 lesions, when you have inflammation surrounding them, when you have inflammation surrounding them and you have areas of non-enhancement within the T2 lesions, the chances of fungus is much higher. So this is a case of mucormycosis. We can see premaxillary and extracorneal T2 hypointense tissue, all non-enhancing because it's an angioinvasive fungus. So this is typical of mucormycosis. Another case, similar T2 hypointense tissue with surrounding inflammation. We have non-enhancing area here with peripheral restriction. This is a fungal abscess in the intraconal space. Now, not all fungus acts like this. Aspergillus can go chronic, can go invasive and chronic, has very little reaction around it. So this is premaxillary, infraorbital, foramen and extraconal, and showing homogeneous enhancement, but restricting like fungus. So this, when we see this combination of something that is really dark, looks like a fungus, we generally have IgG4 pseudotumor and aspergillus. In India, you should not forget aspergillus. So this patient was a renal allograft recipient, and this came out to be aspergillosis. Mucormycosis does not enhance, aspergillus does. This was a bilateral case of lesions involving the lacrimal gland. When it's bilateral, think of systemic. So this was a IgG4 case. It could very well have been Wegener's or sarcoid. You can't really differentiate until you do more tests. So these were a bunch of T2 low lesions. I just want to finish this last case. Very often we find it very difficult to figure out if you have an early orbital apex syndrome versus early fungus. So usually we go by, is the sinus involved? In this, there was some sinusitis. So we did a biopsy. We got nothing. There was no fungus. They treated with steroids. And then 2 months later, it became worse. The amount of enhancement increased. The sinus became worse. They redid a biopsy and they got aspergillus. Despite treatment in February, from December to February, it worsened, involved the cavernous sinus, and thrombosed the ICA. So this is the diffusion restriction as it changes, becoming worse and darker in the apex, becoming worse and darker in the apex and the cavernous sinus before creating an infarct. So we have to be really careful with these. There's nothing that I can say apart from image earlier rather than wait for 2 months if your patient is not responding. Do it earlier to show the change of fungal signal in the orbital apex, because that happens. Just finishing off with an optic nerve glioma, everyone has seen these, but we got this interesting case where you had an atypical looking optic nerve glioma because it had this black thing. So we imaged it further, did a 3D, found a scolex at the anterior end of it, and then gave a medical treatment, and it calcified. Optic nerve became normal, so this was an optic nerve neurocysticercosis. So if you find an atypical finding, aggressively image. Do something new, do something more advanced in terms of sequences. Thank you. Thank you for your kind attention.
Thank you so much, sir. That was really pearl to the existing knowledge. Yes, one important thing that these days diffusion weighted image helps us a lot in differentiating the malignancy or the neoplasm from any other benign lesion, benign condition. So that is very important in our practice. Sir, would you like to add something?
So can you tell me what is the role of MRI in thyroid-related orbitopathy? Thyroid-related orbitopathy.
Right. So it's very so thyroid ophthalmopathy is very clearly visible in terms of enlargement of the extraocular muscles. It has a very specific pattern. Starts usually with the inferior or medial, and then goes to the superior. Right. So usually starts as unilateral. I mean, we see lots of cases where they're bilateral. In some cases, it might be unilateral also. But if you have this pattern of enlargement, where it's starting with the inferior and medial, chances are higher. Retroorbital fat increases. Even intramuscular, you can see areas of fat deposition on the MR. I'd like to say definitely one case that we saw which was very interesting was bilateral only levator palpebrae superioris involvement. That is a atypical pattern, but it is the most common atypical pattern apart from the normal. So if you see a patient with bilateral LPS enlargement, that is also thyroid ophthalmopathy.
One small note, I think, madam.
Yes. Yes.
So in thyroid eye disease, the muscles will be enlarged and the tendon will be spared. And basically, as you're a radiologist.
Yes,
right?
ma'am.
So as ophthalmologist, what we see in MRI is for activity. So we always take an MRI to see only if there is an active disease, because the treatment depends on the activity. If there is an inactive disease, it doesn't warrant any treatment as a physician is concerned. If there is an active disease, then we go ahead with either steroids or immunosuppressants. Now there are so many biomolecules which have come up with which we treat thyroid eye disease. So T2 weighted images, if it is hyper intense, if the muscles are bulky, thyroid eye disease mainly the pathogenesis is it imbibes water, there is fat proliferation. So anything which has water is white in T2. So in T2, if the muscles are white, hyper intense, then it means the disease is active, and it is taken at the mid level. We see at the mid level. That's one name.
Thank you, sir. And one more question, that we had a little bit confusion, and I know that when the mucormycosis was so much popular, that I think we thought that ENT people are the first person to do FES, and still there are a lot of controversies, so many a diagnostic and a clinical appearance of mucormycosis. Can you tell me, highlighting the point, which is the earliest sign for a mucormycosis is to be detected? By MRI.
By MRI?
Yeah.
So we had around 200 patients at our hospital.
Okay.
Because Gangaram was a referral for mucor in Delhi. So the earliest sign that you can find is actually in the nasal cavity.
Okay.
So what happens is that the turbinate that it involves, because it is angioinvasive, it stops supply to that enhancement of that turbinate. So that turbinate turns black on the post-contrast study. So that's called a black turbinate sign. It's one of the earlier signs.
Okay.
In all of our imaging, we actually found that diffusion restriction and non-enhancement in soft tissues anywhere, whether it is in the turbinate, it is in the tissue near the medial canthus, or if it is even in a sinus, it is more likely to be mucor. Ophthalmic artery invasion is one of the earliest signs. I've seen it happen with as little as one air cell involved in the ethmoid. So that pattern of spread, where it is looking like it is going along vessels, is the hallmark, and it sometimes creates infarcts in soft tissues distal to that. That is also a hallmark of mucor only.
Right. Thank you, sir. Is there any question from audience, please? Because of lack of time, I think we'll finish this session. And I think I thank all the speakers and also my co-panelists and also the audience for making this session Pearls in Orbit and Oculoplasty one of the interesting one. Thank you. So with this one, we finish this session. Thank you.
Found that diffusion restriction and non-enhancement in soft tissues anywhere, whether it is in the turbinate, it is in the tissue near the medial canthus, or if it is even in a sinus, it is more likely to be mucor. Ophthalmic artery invasion is one of the earliest signs. I've seen it happen with as little as one air cell involved in the ethmoid. So that pattern of spread, where it is looking like it is going along vessels, is the hallmark, and it sometimes creates infarcts in soft tissues distal to that. That is also a hallmark of mucor only.
Right. Thank you, sir. Is there any question from audience, please? Because of lack of time, I think we'll finish this session. And I think I thank all the speakers and also my co-panelists and also the audience for making this session Pearls in Orbit and Oculoplasty one of the interesting one. Thank you. So with this one, we finish this session. Thank you.